Let us start. Thank you very much for coming. Much appreciated. I'm going to do a very, very brief introduction of why we are here today, and introduction of the people participating in the panel. But because the priority is to listen to them, I'm not going to talk about it. So, design is a big word. And most of us have diverse understanding of design. So I will share my understanding. Design is about creating possibilities for better living. Design collectively studies where is the potential for diverse group of people to take action. And identifying what matters to them is essential to designers. So that's how I understand design. And the second word that today is important is care. And I think that care is also understood differently depending on who is talking about care. And so care nature is about people taking care of people in times of need and stress. So it's not an easy task. Care takes place in the context of relationships. Caring requires capacity and mutual learning. A priority in healthcare should be to focus more on human relations. But as I said before, it's not an easy task. So this is going to be the focus of the conversation today, design and care, and in particular, how design can help enhance caring capacity. I think that caring, as I said, is not one thing, but it requires capacity. Without capacity, there is no care. And to develop this conversation, we have two very important guests, Thomas Zeltner and Hargraves, that will be sitting here.
Not yet.
Not yet, but soon. I thought about introducing them, and I said, well, if I introduce them, I will read their bios. And their bios are roles and functions, and they're much more than role and functions. I can tell you that Thomas currently is the president of the Red Cross Switzerland, and he has been for about 20 years, right, the Secretary of Health of the Federal Office of the Swiss government. And Hargraves is Associate Professor of Medicine in Mayo Clinic, but he's a designer. And he works in the care unit, which is the knowledge and evaluation research unit. So he's a researcher working with researchers at Mayo Clinic. They have a very nice office. It's very interesting to go and see how they work. But for example, I was saying they are people, right, not functions. So yesterday I asked Ian, how did you learn German? And the answer was working with organ pipes in Germany. So there you go. There is much more for all of you to discover about these two people. I would like to thank profoundly to Balthasar Hug to open the door of the hospital. But I think that he also opened his mind and heart and said, okay, let us try this. Why not? And I would also like to thank my boss, Jacqueline Holzer, who is the dean of the School of Design, Film and Arts. And also said, like, well, let us try this. So both of them were very open to explore what could happen today. Let us start. All of you have the agenda on the seat so that you know what will take place. Thomas and Ian will talk for 15 minutes, and then we will have a panel discussion. And now I pass the microphone.
Okay, thank you very much, Guillermina. So a warm welcome to everyone at Lux, which is a central hospital here in central Switzerland. So it's quite a large hospital. So we have about 50,000 inpatients a year and about 900,000 ambulatory contacts with patients a year. And so we're welcoming you here. And it was really interesting when Guillermina contacted me and said, well, let's have a look at design and medicine. And I was sort of stupefied because design, we don't know what design is as a clinician. We don't talk about design really, right? Maybe drug design or something like that. But we know about the power of design. Mm-hmm. So whoever owns an Apple iPhone or so know what design can do, about the working process, about intuitively working in a process. So this is something really powerful. So maybe we need to do some reframing within medicine, maybe.
Okay.
So that's a question maybe for later. Mm-hmm. And I'm really happy that two specialists, Thomas Zeltner and Jan Hargraves, will introduce us into this area, which is really important. So one point is, how do we work? What our work processes, how could we look at them, how could we design them, what about the new generation of physicians, how will they work, question mark. They have problems, we know about that, or let's call them challenges. How can we go about those? And also the contact with the patient in the clinics, how can we design our contacts there, like in decision making together with the patient. So we are very, very much looking forward to your presentations and the discussion. And I have to say, maybe as a last word, that lots of clinicians told me they would be really interested to be here, but they can't be here because of their clinics that are going on. And they will be very much interested in the video that is being taken here. So thank you very much. And let's start.
Let's start. So,
well, thank you so much. And do I need to take this? I understand. Okay. Yeah, thank you so much to give me a chance to address. I think it's going like that. Yeah, okay. So thank you very much that I can be here with you. And I was asked to talk about or introduce, and we will discuss that, about 3 issues: design for better teamwork, design for better work-life balance, and design to increase job satisfaction. And my key message is, really, all these 3 questions are not academic questions just for the fun of it, but they are of incredible urgencies. And I must say, if we do not solve these problems, the Swiss healthcare system will collapse, period. Because, and I will come back to, let me go to this picture first. The workload in hospitals these days is such that 50% of the people are close to burnout or want to quit, period. And they're doing it. They're reducing, and there is no light on the horizon because demography shows that we're having more patients and fewer health professionals. And the point is, and maybe you can talk about the US afterwards, in some way we're crazy. We're not forming enough healthcare professionals. We know it, and they will get shorter and shorter. And in that respect, nobody really knows how do we run our hospitals in 10 years or 20 years. And we have to work on that. And there are a couple of things we never talk about it. One question is, and I'm looking at Dr. Hu, we all as medical doctors, we are so trained to say patients first. And it does not matter whether we work 18 hours, 19 hours, 20 hours with shifts in the nights. And we never think about our own health and balance. And, or at least that was, the culture for many, many, many years. And that is something we need to really change. I have only one German slide. If you're in charge of a health institution, if you're not aware that you need to be as careful as you are for your patients, as careful with your healthcare workers, you're doing a bad job. And that's actually an American, again, very smart guy who said that. So we need, as people responsible in the healthcare system, to say our nurses, our physiotherapists, our doctors are as pressure to us as are having a good care. Because if we don't do that, they burn out and they leave, and we cannot replace them, period. And the question is really how you, with design, can change that. And I say that really, we're not interested that you change something in 15 years. We need to look into things. How can we change by design processes and design that things change within 1, 2, 3 years? And that's actually the message I wanted to bring across. Now, let me just nevertheless go quickly into patients and what's their actually needs. And I go there, and many of you may know this Maslow pyramid. You know, if you have, it really prioritize needs. And on the basis is actually just the needs you have to survive. You need water, you need food, you need warmth. If that's not given, then you don't come to the second level, which is security. The next one is intimate relations, friendship, and the top is then really feeling well and accomplished. That's the normal human behavior. When it now comes to patients, and I will not, the thing that we need to offer them, of course, as physiological needs is at the bottom, safety, physical safety, and love and belonging. And that's actually where the healthcare comes in and where you as design can help. One of my matter of heart is really that we do whatever we can that patients leave the hospital safe and have no additional health problems. 1 out of 10 patients leaving our hospitals has an additional problem, be it an infection, be it some toxicity, etc. So we need to work on that, and that, unfortunately, I must say, can be done. I look at him at Mayo, you know, 0 additional deaths or hospital-acquired infections can be done and should be done. Second, design for better respect of patient privacy and dignity. That's really something, particularly now with chronically ill patients, we need to look into that. And last but not least, we can do a lot for better design in health literacy. You know, we know that the 2 parameters which differentiate in a population whether you're in good health or not good health, the biggest one is your wealth. Wealth and health are related. The richer you are, the healthier you are. And the second one is your level of education. And if we can help bringing the education up, and there are many ways to do that, we'll certainly come back. Let's talk about the doctors and the healthcare professionals. They too have their, of course, their hierarchy and need you know, physiological need. They need the infrastructure, they need the equipment, safety, they need clear roles. Who is responsible for what? Now, I was just recently with my hat as Red Cross, you know, talking about emergency teams. And emergency teams, everyone needs to know and rely on the other person. What is this person doing? What is that person doing? And if that's not clear, things go wrong. And we had actually to look into a condition where a patient died because the roles were not clear. And the question of guilt afterwards, how could that happen? And why did that happen? And why were we not smart enough to know precisely who is doing what? And the patient died, I must say, silly, because the roles were not clear. The last one is belonging and love is need, collaborative communication, and improved share decision. You will come back to that. And I think, again, here, quite a bit can be done with better design for teamwork. And here, I think there is a big gap in our system, and we have to look into that. Design for increased job satisfaction to prevent burnouts. And last but not least, design for better work-life balance and career development. Again, here, I think, I don't know, I don't need to talk too much about that for those working in hospitals. Again, we're a little better, you know, and I don't know how many young medical doctors are here. There are rules how much they should be working these days. There is a federal law on that. Nobody cares about that law. They work way too much, and nobody controls it because it would need that we hire even more medical doctors, and actually it is a kind of a scandal. Whose needs now come first? And it's actually interesting, and I took that about, you know, what are actually what patients want and need. It's, they want, of course, a clean site. They want information where to go, and I was laughing when coming here. This hospital too, it's not easy to find your way as a patient. They want clear, and they go down, clear and easy to understand doctors, involvement in the decision and reduction of symptoms. You know, that's not what they get these days because doctors and nurses don't have the time to speak to them enough. I don't go back to that. We have seen that and we know it and we have to work on it. So whose needs come first? And I bring that up. Maybe this is the wrong question. And I go back to another American, Donald Berwick, who said that, and please read that carefully. And he is an incredibly knowledgeable guy. I think healthcare is more about love than about most other things. If there isn't at the core of these two human beings who have agreed to be in a relationship where one is trying to help relieve the suffering of the other, which is love, you can't get to the right answer here. We always have to think, actually, healthcare is not about the patient and not about the doctor, it's about the relationship. And how do we create this relationship of trust, of support, and how can we really do that? And we know it. It's trust, knowledge, regard, and loyalties are the four elements that we need to work on and work with doctors and patients. And that, at the end of the day, brings joy to the work, and that's what we want our doctors and healthcare workers to have. And I'm getting to the end. For having a good doctor-patient or nurse-patient relationship, whatever, to build trust, knowledge, you need time. And you need room and space where this intimacy of a relationship really can be lived. Think of our overcrowded emergency departments and how it is possible. So again, here, I think design that gives more time for fruitful relationships is key. And design that allows for fruitful, time for relationship and These are two things I think you and we need to work on, and it can be done. Let me end, and then we come to the discussion with this picture. I can't omit showing this. This is a child in an Ebola-affected country in front of a hospital. They had no space in the hospital, and 3 hours after this picture was taken, the child was dead. And it's terrible, I mean. And I just say that here and now, that we're talking about problems in the healthcare system. Don't forget that more than 2/3 of the planet's people are more likely to be in that situation than in the one we're in. And nevertheless, don't forget about that part of our responsibilities too. Thank you.
Yeah. And now we continue with Ian. And they are connected.
They are connected, other than one after the other. I'm on? Yes, I am. So, good morning, everybody. It's wonderful to be here and have the opportunity to spend some time with you. Thomas, thank you for kicking us off. There is definitely intersections between what we're going to talk about, and so I'm looking forward to exploring them here and here as we move through the day. So, my name's Ian Hargraves. I work at the Mayo Clinic, which is a large academic medical centre in the United States. An academic medical centre is one that not only provides care but also trains clinicians, has a lot of work and research, and that side of it as well. It's oddly located in the middle of a cornfield. In Minnesota. So it's located in Rochester, Minnesota, which is a smallish city by American standards, 120,000 people. It developed out of, like I say, a rural community and just grew and grew and grew in over time and reputation and commitment to the care of its patients. It's a large institution. It has 3 campuses around the country. So this in Rochester in Minnesota is the primary one, but it also has campuses in Florida and Arizona as well. Rochester is a bit of an odd town. It's a company town, so I think about 40% of the population are associated with the clinic in one way or another, so it's a very particular community. My training or my background is in design, so I, coming to this, had no formal or no informal either medical training. I was educated very much in the environment of the Hochschule Lucerne, So this is sort of the environment in which I developed as a young designer. But these days I work both as a designer and as a researcher, predominantly in shared decision making. So mostly I publish in medical journals, which is an odd thing for a designer to be doing. As I say, my work is primarily in the field of shared decision making, which in our particular group, we've developed over the years a different stance on what shared decision making is to what it's commonly thought of as. So for us, shared decision making is very much the bread and butter of medicine. It's not an add-on. It's simply the conversations in which patients and clinicians talk together to figure out what to do about a problematic situation. Shared decision making itself developed out of somewhat different ideas. So it developed as a counter to excessive paternalism in medicine. It also was associated with the evidence-based medicine movement, the idea that good, solid knowledge should stand behind medical decision making as much as possible. So the way it practically developed was with an emphasis on the involvement of patients in making decisions about their own care, primarily through the process of weighing the pros and cons of the options alongside their clinicians and relating them to their personal preferences in order to come to a decision as to which treatment or plan of care was right for them. And so, to begin, I'm going to show a little bit of the sorts of things that we design in our unit to support shared decision making. So I'm just going to switch carefully to here. This is a prototype tool. It's still in development. It may have a few bugs as we go through. We'll see how it behaves. But this is a shared decision making digital tool designed to help in the case of treating patients who have been through surgery for lung cancer to make decisions about whether to continue with some more medical care, chemotherapy, or perhaps other options. And so I'm going to click here. So it allows the clinician, for example, to select a stage of cancer that this patient has, and it will display the risk that this particular patient has of dying within the next 5 years from lung cancer. And then you can move to making decisions around whether to introduce chemotherapy. So if you start chemotherapy, what this display is indicating is that 10 of those people will avoid death as a result of starting a course of chemotherapy. And then there's information about what these different treatments involve, so the burden of undertaking chemotherapy and the kinds of side effects that one might experience. Let me switch back. And so I called this digital decision aid design the design of nice interfaces that medical professionals can use with their patients. Except it's not that at all. What it is conversation design. This particular tool is an artifact of the effort to try and improve the conversations that patients and clinicians are having together in difficult circumstances. And so it didn't begin with the need to create a tool. It began with an oncologist who approached us saying that he was having these conversations with patients and his colleagues were having these conversations with patients, and they were very, very difficult conversations to have, and they asked if we could do something to help them in this process. And so what we did was we observed these conversations, primarily through video recording them. So we'd set up little GoPro cameras in the consultation room and watch what these conversations were like. And what we found was They were hard and they were a mess. So what were the reasons for why it was so challenging? Well, one of the challenges is that these patients have been told that they have lung cancer. They have very quickly moved to surgery to have the cancer removed. In many instances, by far, not all by any means, the surgeon has told them after surgery that this operation was a success. They got rid of all the cancer and you no longer have cancer, you're cancer-free. But the reality is that whilst all the cancer that can be seen has been removed, we don't know if there's little pieces of cancer floating around that might come back. And so some patients, when they begin this conversation, are walking into the room thinking they're cancer-free and they're just meeting with a medical oncologist for follow-up reasons. Other reasons why these conversations were difficult is that there's new therapies increasingly becoming available beyond chemotherapy, and clinicians in some cases are struggling to keep up with what that evidence is. There's a number of technical features which are very different from other approaches. It can be difficult to keep that in mind. It can be difficult to figure out how to talk about them with patients. Another challenge is that there was a reticence to have these conversations. So some clinicians, even oncologists, were reticent to raise the idea that the patient might still have cancer. And they were reticent to share the seriousness of the situation that the patient was in. And so there was sort of this ducking the issue, talking around what was going on. And it's very confusing for patients to follow. They were, bits and pieces were coming at them. A lot of emphasis on technical details, going down into the minutiae, that patients didn't know why they were being told this, didn't know what to make with it, but it certainly made the clinician seem like an expert, even if they weren't really talking about fully what was going on for the patient. And so out of this experience of observing these conversations and getting a sense of what was trying to happen in them, why they were difficult, and where needs were to try and support these two people in a difficult situation, work through the work that they need together. Our next process is to develop initial prototypes of something that might help. And so we would bring these prototypes into the clinic. We would ask clinicians to use them with their patients. Again, we would video record them, and we would get a sense of if they're working or not. And so this isn't from this tool, but it's from much earlier work. It's a paper-based decision aid. And you can see on the left-hand side what conversation looks like without using this tool. And you can see once it's brought in, the patient and clinician come around together and start working with it directly, one-on-one. And so if I switch back to this tool, and I'm just going to reload it, perhaps we can see that there's a lot more going on here than what you might immediately think. It begins slowly and quietly, in fairly simple language, beginning to open up the idea that there is actually a serious risk that lung cancer could return, but also introducing the idea that there's ways that we might work with this risk. It starts with a minimal presentation. This is reflecting the way that the clinicians were picking it up. Some clinicians wanted to pick up the idea that there may be cancer with the sense that there were things that we could do, chemotherapy for others. Other people found that it's important to start by establishing what sort of risk a person's at. And so this is a way of introducing the magnitude of what the patient and clinician are dealing with. There are these new treatments available. So gene-related treatments, immunotherapy-related treatments. More have been added since we've developed this, and we're revising it as well. So in addition to the comparison with chemotherapy, we can also look at the potential of these new medications. Now, one of the challenges and some of the details that clinicians went in with patients is the fact that we don't really know how successful or how helpful these medications are going to be, because the trials of them are still ongoing, the results aren't in, but the indications are that they're promising, and you can see that the promise looks significant here. But often they would dive straight into the details of why we don't know, and that could derail the conversation. But there were some elements, or some patients, some occasions where it was helpful to dive into why we don't know. And so we have this very small, helpful thing here where we can say, well, why is it that we don't know? And one of the primary challenges is that we have good data for chemotherapy presented in terms of your chance of being alive in 5 years' time. But the trials that are ongoing haven't completed 5 years. There is no information about how many of the patients who began in this trial are still alive at the end of it. So what these trials on an ongoing basis are reporting is what we call disease-free survival rather than mortality. So that's the chance of you being alive without lung cancer within 4 years' time, which is different than your chance of being dead within 5 years of lung cancer. And so it's not apples and oranges. And so this is a way of delving into that. And so we gave clinicians tools to give patients an approximation of what's going on, recognizing that we really don't know, but trying to give people something to think with. So the emphasis is on the conversation, what's needed to help this conversation design, not digital interface design. And so we've developed a significant number of these tools for various conditions. I want to quickly move through other work that we're doing around the evolving nature of shared decision-making itself. So what's happening in the United States is a significant number of professional organizations with their guidelines are making strong recommendations that shared decision-making should be happening. There's policy promoting this. So in the UK, for example, the NICE guidelines for the National Health Service are saying that this is important. It's even can be tied to payments in the US. So for some conditions, Medicare will only pay for the service if there was shared decision-making involved. So there's a strong push for shared decision-making to be happening. But at the same time, when shared decision-making efforts are trying to be brought into practice, what the research community says is that the attitudes of clinicians are a very strong barrier to this being adopted. And so clinicians will say, well, I'm already doing shared decision-making. Or they'll say it's not relevant to my practice. So there's a bit of disconnect going on. And we actually saw this disconnection as well. So when we look at videos from different types of encounters, we see some conversations which are terrific, but there's no classic shared decision-making going on. And then we see conversations where people are playing by the rules, following this pattern, but the conversations themselves were terrible. So there's sort of disconnect. And so what we began to see to unpack was that there were different ways of doing shared decision-making, and there was no simple recipe. So the classic formulation is the clinician shares details of the options, the patient reflects on them, weighs them against their preferences and comes to a determination. And so a case of something like this is a woman with diabetes, sees her diabetes doctor, her blood sugar isn't well controlled. They discuss the options, weigh the pros and cons of them, and eventually settle on it's time to start insulin. Classic weighing of the benefits and the harms. But then we'd see other conversations such as the same woman perhaps who has been out cycling with her daughter and grandchild with the insulin, her blood sugar has dropped, she passes out while she's cycling, falls on the road, emerges bloody and bruised, and she's meeting with her doctor. The daughter's in the room and is adamant she wants her mother off what she calls that stuff, the insulin. The patient is torn because she's scared of going back on insulin, but she's also scared about not taking good care of her diabetes. And so they have to work through what to do about the situation. Weighing the pros and cons of the options, not going to help a lot here. Or the same woman who works in a gas station recently lost her driver's license, which means she has to take public transit to work, which in the States means that she had to 2-hour extra in her day devoted to the commute, wasn't able to do the sort of healthy cooking that would support her diabetes. At the same time, the cost of insulin has increased 8-fold, and so she's skipping doses simply because you can't afford it. And so the patient and clinician have to engage in problem solving to find a way to move through this. And so eventually out of the problem solving, they recognize that maybe there are other insulins, maybe there's financial aid possible, and maybe the patient can use these other insulins, which require her to inject much more frequently, and they can create an environment at work where she feels that this is possible. And finally, conversations where perhaps the same woman or a similar woman much later in life is talking with her doctor. She's now on dialysis 3 times a week. She's been that way for 5 years. When she started, she was so relieved that this technology was available. But now she feels torn apart by her experience with dialysis. She feels like she's fracturing. She's lost herself. With her daughter and with her doctor, they begin to explore the possibility of moving towards more conservative or palliative approaches going forward. And so they talk together and try and find a way forward out of that. And what we believe that these are all instances of shared decision making, but they're happening in very different ways. In the first instance, the conversation was all around the effects of the illness, the effects of the medications, the side effects involved, all these sorts of things. And they dealt with them by weighing them in a fairly classical manner. In the second case, the conversation was focused on the different positions that people had in relation to the experience that they'd gone through. And the way the decision was happening was by negotiating, trying to shift perspectives in order to reach a decision. In the third case, the method was problem solving, coming up with ideas, trying them out, see if they can figure out how to make the situation work. And the focus was on the situation itself. And in the final case, the conversation was around issues of being, how to deal with existential transition. And the conversations are much more around developing the existential insight that would allow us to know the right thing to do. And so this purposeful shared decision-making frame, which comes out of this, distinguishes different types of situations in care. It identifies its primary topic. So are we talking about effects? Are we talking about the positions that people have? Are we talking about the situations that people are struggling with? Are we talking about being? Links them to different methods or conversational deliberative styles that are going on that are appropriate for dealing with these matters, and eventually linking them to the purpose of decision making in the first place. And so I'm just going to teeter on the edge of what I would say next if I had more time, and point to sort of emerging ideas in our group. And this is pushing at the idea that we make decisions in order to decide on treatments. medications, all these different pills that a particular person could take. And stepping back and recognizing that decisions don't determine treatments, they determine or they change a person's life. We're intervening in a person's life, how they live it, what it means to them. And when you adopt that type of approach, if you can shift your gaze from the decision of this medication or not, the implications for what we're doing when in our interactions with patients shift, the idea of the meaning and the purpose of decision making changes, and our focus of care moves from the body to the way that I live my life in community with others. And so I'm going to wrap up there. But thank you very much.
Okay. So, very nice half an hour. We have moved from the design of conversations, the design of processes, and it has been very clear that we can not do either or decisions. Do we focus on physicians and providers? Do we focus on patients? If care needs to take place, we need to focus on both. So we need to avoid dualistic ways of thinking or false dichotomies. And the focus was very interesting, that in both cases are life circumstances. The life circumstances of the providers and the life circumstances of the physicians. So we have two different situations that come together to enact care and make decisions together. And those decisions are not about treatment or fixing, but are about life and affects each other's life. The life of the providers, the healthcare system, the life of the patient and the family and society. We can scale it up. So it's quite complex. It's not something that we can do an app or a poster and we can fix it and say, great, we have done a design, let us measure and see the results. So the question for you is, where do we start? And usually we start where we are, and seems to be in a very difficult situation. So what will be your suggestions for the three of you to see where can we start?
So perhaps it's a result of my focus on what's happening in the conversations of patients and clinicians. But I think the important starting point is where we are. The biggest challenge is to recognize what's going on in that conversation and what needs to change. So to make it a little more concrete, recognizing how to act in a situation where we could focus very narrowly on which tablet, which pill, and risk missing what's going on in the patient's life. Or we could jump back and say, well, there's all this stuff happening outside. There's this biopsychosocial factors, what's going on in what we call context. But you follow that and you quickly get to issues of economics, politics, geography, culture, capitalism, whatever. It just gets bigger and bigger and bigger. And you can't adopt the stance that I'm going to fix all the societal ills before I'm in a position to care for you as a patient. So what clinicians have this skill to do with their patient is to find the space in which change is possible. Maybe the minutiae, maybe the context, but more the actual situation that needs to be changed in this particular phase. And so the art is to find the place where change is possible and the scope at which it can be changed, recognizing there's always more to do.
Well, and I really think that, situations are pretty different in different parts of this planet, even in high-income countries. And my priority would be on time management. How do we give healthcare professionals the time they need to interact with patients and I must say, and their families? You know, we're often not thinking that actually family members in chronically ill patients take a huge amount of care. So we know it, doctors just simply and nurses just don't have the time to sit together with patients and their families. Was measured again. I mean, doctors talk to family members during a whole period of time of a patient in the hospital, 2 minutes. And at the beginning, maybe hello, hello, and then at the end, don't forget to take the pills with you, etc. And so much can be done in that respect. We know IT could do a lot, delegating things downwards, it could do a lot. So I would start looking at where is time spent and how can we improve that.
Thank you very much. I have sort of like two approaches, and one is a more theoretical one that I mentioned already. So like design and medicine, how can we bring those together? So we're socialized in a different way. We use different kinds of vocabulary. So design for me is something strange, maybe I might say, or it's interesting. I get contacted by you and you talk about design. And I don't see much design in my everyday life. So it was really interesting to see. So how can we reframe that? How can we bring design more together, design and medicine? So we saw some very interesting examples, like in designing how to talk to patients and things like that. Then the second part I think we should discuss is hands-on. So everyday problems. So there are lots of young physicians. You mentioned that in your talk already. So we lose 30% of our physicians. They just get lost over the years. And then we heard that more of them leave their jobs after a few years because it's too stressy, whatever, workload, family life, work-life balance, and so on, don't work. So hands-on problems are, we have a lot of young physicians. They come and say, I want to work 60%, 80%, not 100%. So we need more physicians for that. And on the other side, you have the finance guys who come and say, well, next year you will have less money and not more money. And now, how are we going to solve all this? Question mark.
Yeah. The issue of time and money is present everywhere. So to start reframing, how can design support healthcare systems and people working in healthcare systems that have a lot of overload? Time is a challenge. As we were talking, why this is an hour and a half conversation? Because physicians don't have an extra hour and a half in their days. So asking physicians to come here today is a challenge. They cannot afford it. So a conversation needs to take place, but there is no time for that conversation. And that's the main barrier. So we go back to time and making time. People need to eat, but most people or most healthcare providers are also working for lunch. They need or to check email or to do administration tasks or to catch up with something. So I think this as a beginning to start a conversation, and it will be a process where learning will take place. Yeah, how do you do it at Mayo Clinic? How is that design and medicine works together? What's your secret?
secret.
Could be plural.
Our secrets that assumes that I have one.
Yeah.
So it's not an easy question. I will say that my focus is really on this interaction between the patient and the clinician. So I tackle less the more system and process level contribution that designers can definitely make in that context. So maybe I can talk a little about the issue of time as it manifests in this space here. So there's work in our team looking at the idea of an unhurried conversation and what's involved in creating an unhurried conversation. One crucial component is the number of minutes it takes. But another crucial component is the rhythm and the grace by which you can move through the time that's available, deal with time as a constraint in your interaction with the patients, knowing what to leave in and what to leave out, where the emphasis should focus. So, for example, we often see with young clinicians or medical students a lot of time spent describing technical minutiae that goes way over the head of the patient and doesn't actually leave anybody in a better position to be able to make the right sorts of decisions that would make change. And gradually, as clinicians become more experienced, the better of them are able to step away from demonstrating their technical expertise and are able to focus on what's before them, who's before them, and move through that space with grace within the time that's available. And so I think cultivating not just the ability to squeeze things in, but the ability to move with grace and rhythm through the time that you have, at the same time making the push for more time not be the patient's problem, but make it the system, the clinic, the environment that you as a clinician are working in, and continuing that pressure as well.
Well, all very difficult questions. I would just say something, be aware of the culture you're living in and try to work on the culture if the culture is not right. I mean, I have the privilege to have seen how Mayo is working, and the culture in Mayo is totally different from a university hospital in Switzerland, or probably also in your hospital. And you said it, that, you know, a culture where costs are the first thing you talk about is just not the culture I want in a hospital. And now that starts with and it's very stupid, who sits on the top. If you have, you know, in Mayo, it's always clear, it has been clear, it needs to be a medical doctor, because the culture behind how you run an organization should not be an economist who runs it. And so looking in where are you in with your culture and how do you want to change this culture, I think is a very crucial thing.
Thank you. So when I hear time, I think about efficiency. Mm-hmm. So how can we go about our everyday life? Mm-hmm. Because our physicians need to go home. You mentioned it, but I disagree a little bit with you, because we look at the hours and we know them.
You're an exception in that case. Yep.
But the challenge stays the same, right? Mm-hmm. When can people go home? And they should leave, and in the evening to have their work-life balance, whatever. How do we get that together with financial constraints? Yeah. Question mark. Yeah. So this is a question.
Yeah.
This is not a solution.
Yeah.
And so we discussed this morning, for example, how do you do consults? You know, should we involve the secretaries, that they help the physicians to do certain parts of the administrative part of consulting another physician for a patient or something? So how can we integrate other professions so we can delegate some of the work, so to be more efficient? Question mark. So these are all possibilities. Then a second kind of view is, you know, I talked about iPhone. How can you, from the side of design, show us a workflow, a design of a workflow that works like an iPhone, right? It's smooth, we don't have to read the instructions, and we like to work in it. So everyone is walking around like that people are working like that. How can we do that? Do you have any suggestions?
So part of the success of things like the iPhone, yes, it's innovative and it's new, and I remember 20 odd years ago when it came out and all the shine and sparkle around it, and it's kind of lingered. But I think the success of those products is that they are supporting the things that people are trying to do anyway. That they support interactions that they want with their communities, perhaps in new ways. Or they support bringing recreation into your life. And so in the context of healthcare, the design of a new technology shouldn't immediately go to changing what people are doing already. It should go towards supporting the purpose behind what they're trying to do and try and amplify that and bring it forward.
Well, to make the conversation even more complicated, the Germans actually came up once and tried to implement a model saying we shouldn't talk about the patient. We actually have 3 different groups. Group 1 is what we call simple medicine. So a patient who needs a certificate for being absent or a vaccination or whatever, all these very simple things. Second patient group is acute care patients who go through the system. And the third group are chronically ill patients, multimorbid patients. And I think one needs to look into the use of technology and iPhones very clearly for the different groups. I mean, you can do a lot when it comes to the simple medicine and all these certificates, etc. And probably a very different approach when you have a multimorbid, chronically ill or dying person.
I think you used a very important word, which is technology, right? So we discussed before also about like electronic health records. So nowadays, the whole process of how we work is being mirrored in IT systems, right? So no names here, but in IT systems. And the question is how we bring this together. So we have a tool to design these work processes. We have a tool to use, like your suggestions regarding how to talk to patients. Or we discussed about resuscitation. How should I talk to a patient who says, "Doctor, should I get resuscitated or not?" Question mark. And then what should I say, you know, to give help, like in those situations. So how do you see that? I think that for us in everyday life, this is an important tool for design of workflows.
Okay, but how do we do that? So the first thing we need to do is to understand what's taking place. as with the patient, the same with the processes of the physicians are working. And it might be that is the technology part of the problem. So one of the things, we have a thesis of one of the students, she has just graduated. And one of the things she found out that is very cognitive demanding for assistant physicians to pass from one task to the other. From listening to the patient to talking to the family member for the 2 minutes in the corridor, to entering information in one system and switching to another system. And so that needs to be observed and see how is this technology helping work. And there might be that is helping in some aspects of the process, but it's causing new process or process that we are not aware of in other aspects. So the cognitive capacity that we have for work is certain. And yes, there are more people that have more cognitive capacity than others because they have been trained. Pharmacists can remember a lot of information. So it can be trained, but there is a limit for that. And I think that one thing that is taking place is that that capacity is overwhelmed, is overloaded. And when that capacity is overwhelming, attending to whatever, attending to myself, attending to my colleagues, attending to the patient is difficult. So I think that the processes and at what level is technology and which technology is helping, that needs to be studied. So perhaps that could be a way to start.
Yes, absolutely. And you will notice in the conversation aid that I showed that the process began with observation, with seeing what's happening and trying to understand that, and then trying to design out of that. As you talk about these different places or points of pressure on clinicians, from a design perspective, what we might look for is, again, coming back to this idea of grace. How do we facilitate people moving with grace through the different things that are part of the job? Some which are essential to what it is to practice medicine, some in the United States which are overly concerned with making sure that the patient is billed correctly for what it is that you're doing, which isn't strictly a medical concern. And the grace which you can transition from your time in a white coat to your time in a t-shirt at home.
Yeah, I mean, coming back to the question, why are so many health professionals leaving the job is, and we have data for that in Switzerland, because they say, I'm not doing what I was learning at the university, what I was promised I can do, namely to interact with human beings and help them and get them back to health. I do that 1 hour a day, and 7.5 hours a day I sit in my office and do administrative jobs. And we need just to reduce these 7.5 hours to hopefully 1 hour, 2 hours, and give them the time to do what they wanted to do, what they were promised they can do, and in order to keep them on the job. Otherwise, they're going to leave, period.
So thank you very much. I think there are very good numbers here also. There are studies from the SHUV that show exactly that, 1 hour or 1 hour 20, something like that, with the patient per working day for a physician, which is not very much, to be honest. And so I think that's a really important point. And then you said that we have to look at the team spirit. That's maybe more for the leaders, you know, in healthcare. If I'm an assistant doctor and I'm 25 years old, and my question would be to you, how should I plan and design my career so I can survive and have fun, be on top of the Maslow pyramid? What would you tell them?
Actually, and I dare intervening quickly here, we have one additional non-solved question. The majority of our physicians today, and even more so in the future, are females. And we have to look into to what extent that actually changes the way and the culture in an organization. Because females, luckily, I'd say, are even more sensitive to these questions and work-life balance, and do not accept if things go totally wrong. So we need to look into, our organizations will in the future be dominated by women in all levels of decision. Right now, if you look at the top of the organizations, it's very male.
So one of the places that comes to my mind is medical education. Not in terms of mapping out your entire career, because I think actually asking somebody who's 23 to create the pathway for their life is actually a very poor thing to do. But to bring into medical education an awareness of the difference between the medicine that they're learning in that environment and the medicine that happens in the real world. At a higher level, I think one of the challenges of medical education and medical practice currently in the framework, in terms of the framework that I laid out there, is that there's a tendency to work solely with the language of effects. So in medical school, you learn the effects of illness, you learn the effects of treatments, you learn the side effects, you learn the contextual effects, you learn all the social determinants that affect health, all these things. But the stories I was showing up there demonstrate that actually an ability to deal with the circumstances of patients means that you need skills in actually being able to negotiate how people see the world and work with that. You need skills in being able to problem solve, to figure out how to make things work so that the treatment has some sort of chance of actually being able to be used and its value realized in the lives of patients. And you need the skill to engage with the humanity of people as well. And as the tension, the pressure goes on and on and on medical students to follow this process of efficiency, it's increasingly squeezed into solely understanding medicine from the point of view of the technical understanding of the effects of different treatments on the symptoms of illness. And so I think growing some elbows to push back at the idea that if we just are able to predict what will happen, then the problems of medicine and illness will be solved.
I add something. I agree totally on that. Medicine, and I'm now talking about really medical doctors primarily, is a total exception in our professional world these days. I look at him right now. I just heard a little bit. You were you in the banking, and then you were somewhere there, and then you were coming here, and that's the normal perspective of professional life these days. You really fundamentally change your job every 7 to 10 years. You're in the banking sector, then you go to advisory, then you go to the administration, then you make your own company, and that's what is fun in life and profession. In medicine, we do something crazy, and I was actually talking about that with the head of the FMH. With 30, you become a dermatologist, and you remain a dermatologist for the rest of your days. You're an ophthalmologist, and you're that to the end of the days. And you get, after 45, 50, totally bored about that job. But you can't leave it, Because to become from a dermatologist suddenly a neurologist, no way. And that's one of the reasons why quite a number actually went into alternative medicine, because they look into something they can do which is a little different, or they leave the job. And we need to work on this transparency of a silo job we did, and which is really not helpful.
Thank you very much. I think that's an important thought. I disagree a little bit because because I think the medical profession offers a lot of possibilities, and I think your career is one of the examples, right? It doesn't just mean I study medicine and then I'm in a practice for the rest of my days. No, there are other jobs that are really interesting, that are inspiring. You can go into industry, you can do maybe project stuff, you can go into maybe medical design or something like that. There are many possibilities, and maybe we can take your thought and say, well, let's be more open, maybe also with the medical students, and show them the possibilities they have. Also, our young physicians, they have a lot of possibilities. And it's not just their silo that they're in at the moment, but they have possibilities. And maybe, as you say, maybe these 7 years, check again, after 5-6 years, are you going to stay another 7 years, what you're doing now, or should you develop yourself? Is that part of the answer to my question?
Yes.
We need to move to the questions, to the public.
Sure.
So we can start wrapping up. Who of you have questions?
Thank you very much. It was most interesting. To all of you, I have a question for you. You were talking about conversations. And for me, conversations are, let's say, quite risky undertakings, especially if you have to deal with a medical doctor. You had cancer, and now you're getting into a situation in which you think, as you described it, everything is going to be better, or at least I'm going to be healthy. What intrigues me most is when we're looking at conversations, it is a kind of a risk in the sense that we trust this person. And at the very beginning, this person tells me, well, you're probably not going to be healthy in 5 years. So there is a break of this trust-building relationship. And if we're looking at the conversation as a linguist, it would be really interesting to see how can you deal with this risky undertaking. So my question is, it was a long introduction, sorry for that, but did you work together with linguists, because they do have a different perception and also perspective on this conversation analysis?
Conversation analysis, I remember.
So, great question. The sort of foundation of design that I was educated in leaned heavily on the discipline of rhetoric. And so the use of language to affect change in the world. And so that strongly infuses that work. You raised the issue of the breaking of trust with sharing the idea that you are actually in a dangerous position. I think this word trust needs probing more. Because we all recognize the importance of trust, and coming from a prestigious institution, people trust the Mayo Clinic, but that trust isn't sufficient. It's enough to say the first few words. But I know for myself as a patient, I trust my clinician because they have a training and experience that I don't. I trust them because they have a nice demeanor and they are pleasant to me. But mostly I trust clinicians who help me. And trust develops by taking on the challenges and the problems of others and working with them through that experience and moving it forward. So in your case, it's not just saying you might be dead in 5 years, goodbye. It's actually picking up that problem and working it through, recognizing that it is hard, recognizing that we don't have the answers fully developed today, but I'm going to be there with you, grappling with it together. And that, I think, is the foundation of trust in medicine.
I can just add to that, and I go back to this quote, you know, at the center should be love. You know, two persons, the one person who has a lot of knowledge, who tells the person, I try to do the best for you.
Mm-hmm.
And, you know, predicting the future, nobody can do that. Nobody, even these damn statistics you are showing, you don't know whether you're on that side of the statistic or on that side. Yeah. But the point is that you can give this feeling of trust and love. We're in that together. Mm-hmm. And I will not leave you. And I will give you all you need, even if things go wrong. And I think for all of that, you need a lot of education, mm-hmm. a lot of humility, and time.
Thank you. It's fine. Everything's said.
More and more I see trust not as a thing, but as an emerging property that appears in that process of we are in this together.
Yes.
And I think that process of we are in this together takes place both with physicians, patients, or provider, patient, and the teamwork. So it's a parallel, it's a common area. More questions?
Thank you. First of all, congratulations. Two very good speeches, very deep, very broad, and you still managed to keep the time. I would like to hook into this love thing, right? How do you bring that about? Where do you start? I've had several hospital experiences the last couple of years. Age doesn't pardon. And I made some experiences in the state hospital, so Cantonal Hospital in Basel, where people were actually working according to schedule, reports, time. When you have questions to say, we know what we are doing. Right? I am almost forced to trust them because I have no choice. Mm-hmm. Many years ago, this has also changed, unfortunately. I was also hospitalized in the Clara Hospital in Basel. This is a hospital that had a tradition of being where the people, the caregivers, were nuns. Right? So they had this element of mission and this element of caring, and it was not the time and it was not the money, it was God's job that was given to them. Right? Now, as we know, that population has decreased radically over the years, but the learning and the teaching that they used to have, the mindset continued on for many years. And being a patient there, I felt that I could just let myself drop. I was okay. Right? So I think it starts a lot in that training where today we have the FAGES and all these other titles that are being trained to become efficient, right? Very effective and very efficient. And the patient is just a means to an end. And so when you go into a hospital, it's like going into a factory. Mm-hmm. You leave your life behind, you go in, people you don't know, context you don't know, you are weak, you are sick, you are at the mercy of whoever appears, right? And you stay there, and sometime later, hopefully in a better state, they kick you out back into your life. So the question is, the Maslow pyramid you addressed doesn't stop at the door of the hospital. Mm-hmm. So how can you make that happen in a hospital setting? I've been spending some time in India, not that I want to go into that system, right? But one of the elements that I saw there, not as a patient, thank God, is that the entire family is part of the treatment. Right? They are in the hospital. They are bringing the food. And the medical staff does the medicine and the other things, right? The care, the love, the self-actualization, etc. from the Maslow, right, is being done by the people who usually are there outside of the hospital as well. Right? So this seems to be an element that is missing in our system here, if we go into that direction of the love, right? And so if I listen to you being a bit analytic now, right, not criticism, the solutions that you offer are more time management, better systems, a better process for talking to people, the tools, right? Yes, that's all what we do in factories manufacturing cars also, right? But where is the love? That's what it is.
That what I wanted to say was a different culture, working. Sorry, yeah, no, go ahead.
I can't comment very much on love. I think that's, for me, it's more towards philosophy or whatever. But I think one part is really, really important, what you mentioned, that's family. That's family and the people who come along with the patient. And those are, and we heard 2 minutes, right, talking to them, which is not enough at all. And we see that always again and again. They are supporting the, if I may say so, the process of caring for the patient. They have informations. They can tell us what's been happening before, and they support, of course, the patient himself or herself. And I think that's something extremely important. And I'm not always sure whether all physicians understand the importance of the social surroundings of the patient. And it might be even a neighbor, you know, who is living next door and who knows everything about this patient. And that it might be worth calling that person, or that person comes to the hospital, and that we integrate those persons. And I think that's a very, very important point. Thank you for bringing that up.
I have a surgery here. My first surgery in Switzerland was in the Frauenklinik. And my husband and my 2 sisters were able to stay with me the whole time. And it was very helpful. So there is a process, at least within the Frauenklinik, I don't know all the system, where the family is part of accompanying the process in recovery. They were helping me to eat, they were helping me to go to the toilet, they were helping me walk in the corridor that there is. So at least in some parts, that is taking place, and it was fantastic. And something that I noticed several times when I come here is that nurses are very relaxed and happy. And I wonder, what is their secrets? I want to work like them. So something good is taking place.
Yes, something good is taking place and has taken place throughout the history of medicine. I think I very much resonate with where you're coming from and this idea of love. I think, so it strikes me, the last image in your presentation and the last image in my presentation. Both a glimpse of life and locating the reason for what we do there. There would be no medicine if nobody cared for another person. If people died on the street and we walked by. It just wouldn't be there, it wouldn't exist. It's part of human life. And so it is at its heart that challenge is for that heart to permeate through everything that we've been talking about today.
Well, just to go back to that, I mean, one of the parameters or one of the paradigms, we are also teaching in medical school is never stop having family members access to the patients, even if they are in the hospital. So there should be a continuum of possibility to be with them, and that has an impact on design. We know the best hospitals for that are hospitals where you have only one bed rooms, because there family members can actually stay overnight. They can help feeding, they can help this and that. You can't do that in a room with 4 beds, because then the other patients start complaining about the noise, etc. That's one of the reasons why actually 1 bedroom or 2 bedroom hospitals make sense. And the second one is the economic part of it. If family members are around, they actually support so much that you don't need as much support by the nurses.
Thank you. So I resonate very much with that, and I think there's, if we come back to our topic, which is design, then I think there are small things that would help in this situation. So you have the patient, and in the children's hospital we have rooming in, for example. That's one of the design solutions, if I may say so. And others are, for example, in a situation that you described before, that someone entering the room where you're at and seeing, let's say, your partner there sitting on a chair, offering a lounge chair if you want to stay longer or into the night or through the night. Do you want to stay during the night because you have a long way to travel here? We could offer you a bed next to your partner. Things like that, which are small hints. You know, it's good that you are here. And we support that very much. I think that could be from the side of design and what you were hinting at, sort of bringing those two thoughts together.
I think that love is in the details. Do we have a question? Okay, Samson.
Yeah.
Okay, thank you for all the sharing. Just a quick question regarding the love, care, and the trust. It definitely, we need personal, human interactions, but that means it takes time. And the question would be systemically how we pay these hours, how we cover these times in the working sheet instead of other tasks, right? I think physicians, doctors, they are willing to spend time if such kind of task are given the same weight as other works. So that could be, if they are paid, they have to, or in a way, this is the equivalent as important as other jobs, right?
Sorry, I need a footnote to that.
Okay.
Can I have the mic? Yes, I would like to investigate what is the cost of not having time. Many times, let's say, I work in traffic safety for a number of years. The cost of doing nothing was far higher than spending 20 million in a well-organized communication system. The experience internationally is that there is a return of 20 to 1 to good efforts on communication for traffic safety. I'm wondering whether we could find the long-term repercussions of not having time to do this dialogue and how many costs are hidden. What do you think?
Lovely questions. One of the things we should be changing and we're not able to change is we should get rid of the tar med. We should not talk about the tar doc who is coming, meaning being paid by actions or activities, because that makes that you add up things that you want to do and the human interaction is actually badly or not paid. So DRGs are already better, but we need to work. We were always fighting, at least communicate that these tar med things are to be eliminated earlier or later. and rather early. And we are now working on, DRG is going into the ambulatory sector, etc. So the payment system has a lot to do. The second thing we're not doing in Switzerland, and we're just, we have actually in parallel 3 systems we could even talk about. One is what is called the system KVG, the healthcare system. But we have, apart from that, the whole area of Invalidenversicherung, and you have the whole area of accidents, etc. And people actually move through this system, and we only calculate what the KVG system is costing. And some doctors sometimes happy if then they can go from that system to the next one, and we need to have a more, a total view on what does actually not spending time in the KVG system produces as cost somewhere else.
Thank you very much. Do I have a second still?
Yes.
Yep.
Yeah, okay. I think these are 2 very, very interesting questions. And I think you mentioned the elephant in the room. I mean, we can discuss about love. That's nice. And on the other hand, there we saw a red glove, right? And that was time, and also the money that you were talking about now. And we know about closing hospitals. We know about hundreds of millions that are missing to the hospitals. This is the reality. This is also something we have to face. And this is not the topic of today. So personally, I won't go into any details, but I think that's really important to have that in the back of the mind, at least. Then I think your question is really interesting, but it's not very easy to ask for the cost of not doing something, which might be extremely relevant. So we have a motion like less is more that might go into that direction, right? So we do things because we've been doing that for years, right? We think, well, that's part of our profession, that's part of medicine. And then someone comes along, does a good study and we see, no, you don't have to do that. It's completely useless. Or like if you have an acute myocardial infarction, everyone gets oxygen in their noses, in the ED, everyone in the world. But there was in the New England Journal a real nice paper saying, it's no use. You can give it or not. Why do you do it then? And there are lots of things like that with medications and all that. So I think it's an extremely good idea, not very easy to solve, but it would be interesting to go about it in scientific work. Thank you.
I could just throw one thing in there as well, is cost shifting. So there's part of our research is around something called minimally disruptive medicine, which focuses on the burden of treatment. So when the patients leave here or the clinic, what is it that we've asked them to do, and how much workload is it putting on the patients? And it turns out it's a lot. Patients have to pick up a lot of tasks. Things can be hard to do. Things that are recommended without necessarily any awareness of how hard it would actually be to follow through on that recommendation. There's a lot of promotion of self-management currently, and it's cast around empowering patients and putting health in people's hands and the like, which is great, sounds very nice, but it can also easily be, you do it, not me do it. And we'll call it empowering if you take on this thing that was actually part of my responsibility. Now the important thing is to know the difference, because there is reasons to give patients or develop the patients the capacity to make life work. But we also need to be careful with the rhetoric of things like self-management and recognize when that is simply cost shifting.
Good. Let us close. I will invite Jacqueline Holzer, Dean of the School of Design, Film and Arts at the Hochschule Lucerne, to close our conversation. Okay.
Wow. Thank you very much indeed. Guillermina, you started about the word design, creating possibilities for a better living. Design is taking into account diverse groups to take action, and we try to find out what matters to them. And it was most interesting for me to hear that we are talking sometimes about human beings being in a conversation, being in a relationship. We were talking about love, huge word, very huge word. And sometimes I think to start a relationship, a love relationship, you need time, which is not easy, as we have heard. And the word culture is really getting important. Culture is a term probably also as different, diverse, multi-perspectively like design. But nevertheless, I think it is worth looking at the culture of the different clinic systems. And for me, also the words trust, knowledge, regard, loyalty are words that are really filled with different values that are important for our culture and also for our society. But nevertheless, we need room, space, time. We're getting also, again, to these concepts. I think it was interesting for me to hear that you all were talking about efficiency and not about effectiveness in English. So what do we do in the time we have right? What is the right thing to do in the time we do have? I think this is also a question design management could help to answer, because you, Jorge, were talking about processes, systems, tools, which is also necessary to talk about in car industries, etc. Probably there we have to shift the mindset. We had a discussion about mindsets of what a medical culture will be in the future. If we can manage to observe, to describe everything we can see in a clinic, in an everyday clinic day, let's say it like this, then we probably can see what is the thing we have to delegate to other persons. For instance, people who have to do all the administrative work. What can we delegate to technology? I love the example of the iPhone. I would call it iMed. But I would also say the iPhone was not only a good thing to do, because we have a lot of young people having psychological problems because they're staring into their iPhones. So we need to think about technology that really support us. And we have to think about all the different, I call them stakeholders. I've learned that from you, Guillermina. In the sense, what is the part of the family? What is the part of the beloved members of our relationships we have in private life? What is the relationship with the people doing the administrative work, etc. All the different professions you have in a clinical life. And then we have to do our design management work. And I really would be absolutely optimistic, filled with hope. If we are looking together at all these processes and systems, then we have probably a chance to find where is the time we could use better. So we need love, and we do need design management to get into a better future. Thank you very much.
Thank you.